Thank you for coming this morning. This is discipline group number 18, APP Tips and Tricks for Telemedicine. My name is Laura Beth-Gifford. I'm a physician assistant at the University of North Carolina in Chapel Hill. And this is my co-moderator. If I can get the slides to switch. Sarah Catherine Thompson from the University of Mississippi Pediatric CF Center, and we have no relationships to disclose related to this presentation. We all know that telemedicine came into our lives unexpectedly in 2020, and it's remained part of our lives to some extent, and every CF center seems to be utilizing telemedicine differently. And there are just a lot of changes that have happened since 2020. So this session is to highlight some QI projects that different CF centers have done around the country. We have 3 speakers who will be speaking to that, and another speaker from the CF Foundation who will speak to policy and insurance limitations that we are all experiencing related to telemedicine. So our objectives today are to identify areas of care in the CF center that telehealth could be beneficial. Number 2, to discuss billing and documentation in relation to telehealth in the CF center. And number 3, to review current licensing and out-of-state privileges related to telehealth visits. So we will get started.
Our first speaker this morning is Abigail Vera. She is a board-certified family nurse practitioner. She treats cystic fibrosis patients at the UC San Diego Adult Cystic Fibrosis Program, where the program provides specialized care and support services dedicated to improving the length and quality of life for adults with cystic fibrosis.
You got it. Choose yours.
All right. So I'm very short, so if you can't see my face, you hear my lovely voice, right? Okay. So good morning, everyone. Thank you for joining me so bright and early. I know these early sessions can be brutal, so I hope you had your cup of coffee. So my name's Abby. I'm the nurse practitioner and the program manager for the Adult Cystic Fibrosis Program at UC San Diego. And I'm here to share with you today on how our CF team utilizes telehealth, really with the ultimate goal to improve patient clinic access for our program. Okay. Technical difficulty, there we go. So I have no relationships to disclose. I first want to give a big thank you to our brilliant team for consistently supporting this mission of improving clinic access for our new patients over this past year. It really does take a village. The UCSD CF program has a total of 4 physicians that cover outpatient clinics on Mondays, Wednesdays, and Fridays. So we are very fortunate. This has been the most physician support we have ever had in our program. The 2 newer physicians, Dr. Jeff Berry, that tall, towering man right there on the top picture with all the little girls there. And he started in 2020, and Dr. Jacob Bailey, which he's all suited up to the left of our medical director, Dr. Conrad at the bottom. Dr. Bailey, he started in 2022. So they're fairly new to our team. As you can see, we have a sizable team and experienced interdisciplinary team that's able to take care of our growing patient numbers. Based on our most recent CF registry data, we provide care for about 254 CF adult patients. As you may all know, with any growing program comes limited clinic availability and access. All right. As you see in our program's current condition, depicted on the graph on the left, there has been a significant rise in new patient referrals and new patients seen in our program from January to October of 2022. 2022 was that year where we started to really struggle with finding appointments in a timely fashion for these new patients. So to give you a perspective, in total, we've seen 50 new patients in 2022 compared to in 2021, where we saw 37. You can see below here in fiscal year of 2022, percentage of new patients scheduled within 7 days of contact was a dismal 20%. FY21 was at 66%. So as you all know, that with any limited access, that leads to delay in timely care for our complex patients. So really, our goal for this performance improvement project was hopefully doubling that percentage. So from 20 to 40% by the end of January 23. So in order to tackle this target goal, we started with our gap analysis, which is basically finding that possible root causes of why we have poor clinic access. So I started investigating on why our percentage was low. So I pulled our data from our EHR database, which provided categorized reasons why our patients are scheduling more than 7 days out. So you see here on the Pareto chart that the top reason is limited clinic appointment availability for our new patients. So that large bar to the left. Second reasons, other reasons why, which is just out of our control, would be patient provider preference, specific dates, location, and pending authorizations was rarely an issue for us. And then we dug deeper and we had those difficult conversations. We had a meeting with our stakeholders, that includes our medical director, physicians, administrative schedulers, to complete a fishbone diagram. And I imagine you guys know what that is. It's not fun. It looks cute, but not fun. But it's really just a tool to categorize the potential causes of why we have this problem. And we identified the top barriers, and it ended up being low new patient appointment availability on our current clinic templates. And another point that was brought up by our physicians was that the new patient appointments were just taking too long. A large amount of time they spend on documentation, med rec, past medical history, just digging through patients' notes. And that takes up a good chunk of their time. And it comes to a point where we typically don't schedule more than one new patient per clinic day. So that makes it difficult for us. Okay, so in order to address what we found in our analysis, we decided to focus on offering telehealth services to our new patients. So our proposed countermeasures here fall into two categories. So first is new telehealth appointments were added to the clinic template. We gathered our physicians' time availability and added new telehealth appointment slots. This was pulling teeth. We also started offering new patient info intake appointments scheduled with the nurse practitioner and the pharmacist to solely just collect medical history data, complete documentation within their scope of practice, with the hopes to maybe even decrease the new patient in-person appointments with the MD. So on October 20th, 2022, our new telehealth appointments went live. And really, this required very minimal training. Everyone is familiar with telehealth technology since the pandemic. So for our second intervention, we created a clear workflow to assure that telehealth appointments offered to new patients were medically appropriate, right? So the nurse practitioner or RNs will review the new referrals that come in. Before, what we used to do is that the admin assistant would take the message or the new patient intake referral, and they would send it to 5+ team members to review the referral itself before offering an appointment. And sometimes it just waits there for days. So, and originally when we would intake any type of information from the new patients, it would be our dietitian and an RT doing that via telephone and just documented in like our system. So that's what we used to do. All right. So I know you guys are burning. What does this NP and pharmacist visit entail? All right. So during these new, these intake telehealth appointments, clinical symptoms can be assessed by the NP at the time of visit and allows the provider to determine if the patient requires urgent treatment or, you need to go to the emergency room, a course of antibiotics, or just a sooner follow-up for us so we can at least at least provide that for them. The NP can assess a need for any imaging that's missing, chest x-rays, CT scans. We can identify and address any patient issues with home O2 access or broken equipment. This will give our RT a heads up and possibly be able to work on these issues before their in-person visit. We identify any referrals that they may need for any specialists, endo, psychiatry, the list goes on. We can assess if these referrals are even urgent, so we can put in a stat referral if needed. Our pharmacist joins the telehealth visit by reviewing, allergies, medications, assessing patient's medication access, possible DDIs she may need to review beforehand, immunizations, even setting up pharmacy locations. All that can be done on that day. And then having the opportunity to even identify any medications that may need an urgent PA to be completed, and we can probably start working on that beforehand. So having that medication list is helpful for the provider, right, as when you see them. And then, of course, any monitoring labs, health maintenance items can be reviewed and ordered that day. So on average, the telehealth visit with the nurse practitioner, including pre-charting, would be around 25 to 30 minutes. That's based on our time study. Okay, so telehealth, I found that telehealth really provides a different view of our patients. Telehealth visits gives the provider a chance to assess their residents, their environment, and provides the opportunity to meet patients' support system in the comfort of their own home. I remember one example, I had a patient gardening during our telehealth. We were outside and she had the phone here and she was showing me her plants and kind of delved into like environment assessment. Oh, do you wear a mask? I've had another telehealth where a patient showed me multiple cats. She had 5, which really opened up an opportunity to discuss the allergy symptoms that she was discussing with me as well. Patients have easy access to their medications and supplements when they're at home. So I imagine you've had this experience where patients would have like a long list of supplements when they're in clinic, but they don't remember what they're taking or what brand or what dosing. And then most importantly, this visit can serve as an opportunity to focus on the patient's priority needs and healthcare goals, which can be relayed to the provider and the CF team to consider during their in-person visit when they meet. So, and then really setting expectations, telling them like, hey, when you come to our appointment, it may be lengthy and that many team members would like to meet you. And then they'll let us know, oh, well, I prefer this first time around to see only a few. So it's really patient focused. All right. So our results, I know you guys are really excited. So since offering telehealth appointments to new patients, the percentage of new patients seen have reached above our target. In January, 45%. So since the launch of the telehealth services, we've had over 35 visits this past year. We have instances where our physicians were willing to see more than one new patient per clinic day, just as long as that new patient actually had that intake appointment with the NP and the PharmD. And then we ended our fiscal year close to 40%. So since our percentage new seen in 7 days improved, you can see in a 14-day mark and 30-day mark, we've significantly improved in 2023. So we ended within 30 days, 74%. All right, so our new patient intake process and providing these services has really reduced overall waste, removed multiple unnecessary steps, streamlined processes, getting to get patients in our schedule. We've reduced patients waiting, for approval and non-utilized talent. So our team members' hours have been repurposed. We've found that the CF physician and the referring physician satisfaction has improved due to decreased non-billable workload and provider documentation time. Based on a time study conducted after offering telehealth services, our physicians' time spent with a new patient in clinic has decreased to an average of 40 to 45 minutes compared to the baseline appointment duration before these telehealth services, which hit more an hour and 15. So I'll take it. In terms of risk avoidance, I've just mentioned, I mentioned this already. We have improved kind of patient safety, decreased potential ER hospital admissions since we're catching them sooner. Financial perspective, more clinical encounters this past year. This has been the most that we've had this past year. And then more importantly, a patient perspective. There's been a decrease in time transitioning from previous center to our center. We've received a lot of positive feedback from our patient surveys, appreciative of one-on-one time that they received with team members and their focus on their healthcare goals. So it has improved our XOC survey participation. And I'm proud to mention that our projects, out of 50 performance improvement projects, have been recognized by our organization. So we won the Improvement Excellence Award for improving patient access for our patients. So that's us. All right. Alrighty. Since the launch of this project, I've learned that change is always hard to embrace. Particularly when you have a combination of staff members with many, many years of experience and some that are fairly new to the CF world, and you kind of have to battle this culture but it's always been done this way. So quality improvement is always an ongoing cycle and will always require change, for you to continually get better. So the key to this is kind of bogging down on why we have this problem. So the involvement of all of our stakeholders was key. In the past, in order to improve access, it's always failed because we never had that proper root cause analysis. And then that big aha moment is really the importance of having those honest and difficult conversations to identify the root cause. So kind of pushing those uncomfortable moments and the need for QI. Okay, so just to wrap up, for future directions, our next endeavor is improving patient follow-up visits within 2 weeks of hospital discharge. Our FY23 baseline data shows only about 34% of patients completed a 2-week follow-up. The majority of our patients that are admitted are the most vulnerable, that are typically advanced lung disease with multiple needs that do get readmitted. We really hope that this will improve patient care access, prevent fires that need to be put out situations, possibly decreasing readmission, and just improving actually clinic appointment utilization for certain clinic days where we just don't have any takers on certain days, such as a Monday morning or a Friday morning. In order to give us the best chance of getting our patients being scheduled, we offer 3 different types of appointments. Not only will it be in person, we'll offer, the telehealth morning appointments on Mondays and Fridays, and telehealth appointments on Tuesdays and Thursdays. So that really kind of opens up, there's really no excuse. We're available from Monday to Friday. When can you see us? So really, these visits are going to be straight to the point, just to make sure that their clinical symptoms are at baseline, they have access to their equipment, nutritional related supplementation, outside referrals and imaging that maybe the hospitalist has recommended during the admission and it just kind of falls through the cracks. And so we've already been offering these telehealth appointments since the beginning of this month. And that's it. Questions?
So we'll take questions now. Either we have a microphone or you can submit through the app for Abby.
I have a question. Do you bill for the NP pharmacy initial visit?
So repeat the question. Oh, sorry. Do I bill for the NP and the PharmD visits? That we have not figured out yet. I think the whole point really is we were in critical need to find any way to connect with these patients in a telehealth setting. And so we're still figuring that out. And I think it's an issue with the health system and how we can bill. Yeah, okay. All right, yeah.
Are you requiring that patients have and are able to use a home spirometer for the telehealth visits?
Good question. All right, so home spirometer for telehealth visits are not an absolute requirement, for us. If patients have a home spirometer, yes, we encourage them to use it before their appointment. However, this doesn't happen consistently. I think everyone kind of has this issue, right? And I think other centers struggle with this. We do have a percentage of patients that just don't trust the readings, or they just have issues with just technical issues, where it works with their mobile app, or they simply lose the device. And I will say this, we have, I say like 20 out of 20 patients, new patients that come in, they tell me either they lost it or they don't use it, or just a slew of reasons. But I do tell patients, if they do have it, to bring it to our clinic, and then we have an RT to kind of like help them troubleshoot and to work with it. Yeah.
Question here.
I got a big mouth.
Yes.
So just to reiterate, were you doing telehealth during COVID?
Yes.
You were already doing it, so this is just kind of a shift.
Yes, this is just for new patients. Yeah, but we didn't.
Curious, did you say you're not billing? Because I'm a PA, and I bill whenever I do telehealth. Is it?
Oh, I see what you're saying. So for these just medical intake appointments, for my whole presentation for new patient access, we just wanted at least, if how do I say this?
You're trying to take the pain away from the physician.
Correct. In order for them to agree to have to see more than one new patient per clinic. So, yeah.
And then, so with home spirometers, we have similar things. People have them.
Yeah.
The cat has them, whatever.
Right.
Just set 'em up.
Yeah.
The problem was that, once it went from free, we were just talking about it with this $600 a month, and you can't generate enough interpretations to justify the cost of maintaining the monitoring.
Correct. Yeah. Yeah, well, our facility doesn't have the dashboard or anything like that. Yeah. Oh, yeah.
I have a question. I understand these are like medical intake appointments, and you're seeing the patient as the nurse practitioner. Now, do you explain to the patient that they might see a different provider when they go for their first appointment? And do they expect, oh, now I've met you, so are you going to be my provider? Has that come up much? And
no, that's a good point. Actually, I make that point at the very end where we talk about their goals. Basically, I say, and set those expectations. You'll meet either our medical director. I introduce either the physicians. It may not be me that's going to see you that day, but the other physicians that will be a part of their care. And they do like to hear that, oh, okay, so it's not just like going to be a different person every time. Okay. They'll say like, oh, it's kind of like setting them up to like, yes, you're going to meet Dr. Bailey, or you're going to meet Dr. Barry. They typically work on a Wednesday, or they typically work on a Monday. And they do like to hear what to expect. Even dwindling down to parking, they get less anxious about it. Because parking is, I don't know, awful in our center. I don't know how you guys feel about the parking there, but yeah, just setting those little things, bringing snacks during a very long appointment, that those little things can go a far way. And you get those. I don't know if you guys struggle with getting participation for your XOC surveys, but a lot of our comments kind of tie in with a lot of the inpatient intake appointments. So and it does improve patient satisfaction. All right, about that? Okay, all right.
thank you. All right, our second speaker is going to be Dr. Richard Belkin he's the founder and medical director of the Santa Barbara Cottage Hospital Adult Cystic Fibrosis Program. He is also an independent group practice in pulmonary and critical care medicine in Santa Barbara and the managing partner at Santa Barbara Pulmonary Associates. He has led several quality improvement initiatives with the Cottage CF program supported by the CF Foundation and Institute for Excellence in Health and Social Systems at the University of New Hampshire, including telehealth. So welcome, Dr. Belkin. We'll let you get
Thank you. And welcome, everybody. Thank you for joining this early session. I hope to share a little bit about our virtual care experience. As was just mentioned, I'm based at a community hospital CF program, so we're kind of a small to medium-sized program. And we've had a lot of evolution in our telehealth since the onset of COVID. And as you'll hear, we actually were involved in a telehealth initiative even before COVID. It's not working. Okay. There. Okay. All right. I have a few relationships, but none of which are related to this presentation. I just thought I'd start with a quote, because I think this keeps me, as well as I think our CF team, a little bit motivated about continuing to do telehealth. But I like the ease of not having to leave home. I also like the fact that I'm not exposed to other CF bacteria while performing the virtual visit. I have a thermometer, blood pressure cuff, a spirometer, thanks to the CF Foundation, and a scale, so I'm able to provide the information to the clinic at a virtual visit. And as you'll hear from me, I think there's a lot of benefits to our continuing virtual visits, even post the pandemic. So I just thought I'd start about what is telehealth. I mean, I think this is probably a review for most of you, but I thought I would just touch on it briefly. It's the remote delivery of healthcare services using telecommunication technology. You can have virtual visit, which is a live synchronous encounter between patient and provider. You can have a telephone visit, which is typically audio only. And then what we've started doing more recently are electronic visits, which are asynchronous online or mobile app communication to transmit health data. So this is usually just communication through our portal. And then there's the whole concept of remote patient monitoring, particularly with home spirometry, which I'll touch on as well. So there's been really an explosion of telehealth. This was a paper that was published in the Journal of Cystic Fibrosis in May of 2023. This looked at trying to define best practices in telehealth, and it actually looked at over 2,000 different manuscripts and narrowed it down to 10 that they thought would contribute the most to the development of best practices. It was in various settings, single and multi-center studies in various countries, different types of cohorts, looking at different types of CF telehealth focuses, including just the development of a virtual clinic in the setting of the pandemic, use of physiotherapy, how can we assess mental health, medication adherence, microbiology-related issues such as Pseudomonas aeruginosa colonization, treatment management, and using whole body vibration training. It looked at various different types of outcomes measured, feasibility, acceptability, patient views, satisfaction, cost, quality of life, clinical outcomes. Really, the outcome of this paper is that we're not quite there yet. Although this is a good start, a lot of the papers that have been published, as far as best practices, we still need some work ahead. So CF and telemedicine. So what are some of the potential benefits? Well, we have improved care access, particularly in rural areas, improved communication, so electronic visits with physicians, texting cell phone with a CF team, improved medication adherence based on text messaging. There's some early signals that perhaps there's some cost savings. Although I think we need to be careful because one study's already been published out of Australia that perhaps, after the pandemic, that they saw a greater than 10% decline in FEV1 in comparison to 12 months prior to the pandemic. So just some things to think about as we move forward. So let's go a little bit through some of the benefits and barriers of telehealth. So there's definitely potential increase for continuity of care. Okay, convenience, reduced no-shows. I think we probably all have seen that where patients, for whatever reason, don't want to come into their clinic appointments, but because virtual visits are easier, they tend to keep those appointments. There's improved access beyond normal clinic hours, potentially increased billable hours, particularly for someone like myself as a physician. Even last week, I was traveling. I needed to see a couple of patients for sick visits. I did them remotely from Northern California. So the ability to do visits in different places, I think, allows better access for patients. Reduce patient travel burden, cost, time away from work, school. I think we all hear our patients who tell us about this benefit. Increased clinic efficiency, the potential for group visits. Improved patient engagement and adherence related to telehealth. And of course, if patients are not coming into clinic, there's the potential for improved infection control. And then even potentially reduction in overhead because potentially less staff may be needed, less space may be needed. So these are all potential benefits. So what are some of the barriers? And I think this is a big one that drives a lot of what we do in medicine, which is financial and reimbursement. And I'm going to talk a little bit more about that later. Interstate licensure, and I think you're going to hear also about that later. Security, privacy, and confidentiality. I work at a hospital where this is really super important. This definitely plays a role, particularly in what platform you choose. And then there's the concept of the digital divide or telehealth inequity, and there are some patients that don't have internet access, and how do we deal with those patients? And how do we make sure that they have equal access to care? Language barriers, equipment needs and technical issues during visits. I think we've all had those. Limited teaching, an inhaler, demonstration, although our respiratory therapist has done a really good job at really stepping that up and doing it virtually. And of course, limited physical examinations, and that may change with electronic stethoscopes and things like that. So back in 2019, this is pre-pandemic, our hospital, in conjunction with Ventura County Medical Center and their pediatric program, and actually had started a virtual care initiative. We felt this was even important even before the pandemic. And we did this through the Virtual Improvement Fundamentals program supported by the Dartmouth Microsystem Academy and the CF Foundation. And as we were developing this program, this was in the early part of 2020, then COVID hit. And all of a sudden we had rapid acceleration. And we had our last in-person clinic day, as I think everybody recalls, around the end of February of that year. We had our first complete virtual clinic day on March 10th. And we really struggled for a while to figure out how we were going to do this in a very rapid way. And we developed this fishbone, okay? And yes, this is a busy fishbone, okay, with a lot on it. And we all, our whole team kind of sat together to try to figure this out. How were we going to deal with equipment, okay? How we're going to get patients lung function tests, how we're going to get them just basics, blood pressure cuff, a scale, pulse oximeter, okay? How are we going to bill for this? What technology we're going to use? What EMR? How are we going to do that? We had a hard time even before this rapid acceleration happened in trying to find a HIPAA platform or a platform that was HIPAA protected. Were we going to do virtual visit webinars to update our patients on all the changes going on with COVID-19? So there's a lot of issues that were going on at the time. So we settled on a set of virtual equipment, scale, blood pressure cuff, pulse oximeter, thermometer. Thankfully, the CF Foundation had supported spirometry, specifically the Mir Spiral Bank, and then making sure that all patients had virtual care electronic devices as best as possible. Again, this gets into the sort of digital divide. We went through various platforms before we ended on Epic. We went through something called Spruce, Doxy.me. We used Zoom, which our hospital for a period of time felt was not HIPAA compliant. And as I said, ended on Epic. And these are the examples of some of the things that we used. And then we had to think about, well, how is this going to be successful? What are some of our short-term goals? What are some of our long-term goals? And we had to think about things like utilization rates, patient experience. Could we perhaps continue? We had just worked on a project trying to reduce unengaged time in person. Could we then translate that to virtual visits? How about no-show rates? Could we potentially decrease rates of hospitalizations? On the provider side, would providers feel like they're providing good care? And then in the long term, what about health outcomes, pulmonary exacerbations, FEV1, BMI, urgent care and ER visits? How would how would all that play out with virtual care? And then of course, financial, and then operational efficiencies, the equipment, the platform, the hospital investment, and all of this. So just a little bit about the platform. It's important that it has a lot easy usability, has good customer service. The one that we use is integrated with Epic, which makes it really easy to use, and it's secure. As I mentioned, we had went through various platforms, and we are using the Epic platform. And we do use in our clinic FaceTime for backup when patients just can't get Epic to work. And when they don't have video access, we just do telephone calls. So this is our this is our virtual visit utilization from 2021 through 2023. As you can see here on the left, more of our patients were virtual. then in person at the beginning of 2021. But then we sort of developed this hybrid clinic where we would have patients who were in person and patients who were virtual. And we've kind of sustained that model really ever since 2021. So I'll just go through some of the changes in government regulations related to telehealth. And this was at the beginning of the pandemic that made things a lot easier. Virtual visit requirements for the originating distance site were waived. Reimbursement became on par with in-person services. It's really important that we got payment parity, particularly for our hospital and for the medical providers who are providing the care and doing the billing. HIPAA restrictions were loosened to use everyday technology. As I mentioned, our hospital, although still was quite strict about that. You could expand telehealth to include other healthcare providers, so physical therapists, occupational therapists, respiratory therapists. So this is really helpful. Out-of-state providers did not need to be licensed in the state where providing services. However, at the local level, this was not exactly the same, so that had to be addressed as well. And then there were telephone and audio codes that were now reimbursable by CMS. So this made the fallback to telephone also a viable option. It didn't have to be audio video. And also virtual visit allowed for new patients, as we just heard about. And then also remote patient monitoring and payments for that as well. So where are we now? Post-pandemic, Medicare beneficiaries in any geographic area can receive telehealth services rather than only those living in rural areas. And that was the issue before the pandemic, is that really telehealth could only be provided in rural areas. Now we can provide it anywhere. Beneficiaries can remain in their homes for telehealth visits rather than traveling to a healthcare facility, again, which is something that was required pre-pandemic. Televisits can be provided audio only, as I mentioned, and again, payment rates are on par with in-clinic visits, which is really important. There's flexibility on practitioners who may bill telehealth, again, other healthcare providers who can bill, not just physicians or APPs. There's an expanded list of Medicare-covered services that can be provided, and virtual direct supervision flexibilities, however, are going to be discontinued. Okay, so let's go a little bit into our data, okay? So if CF Care delivered as a mix of in-person and telehealth, what mix would you prefer? These are patient preferences. And interestingly, in our center, mostly telehealth, which I thought that was really fascinating, actually, with one in-person visit per year. So I think our patients really got used to telehealth visits. Although there are a subset, as you can see in the red column here, that do prefer mostly in-person visits. So it's just something that we noted and I think took into account in the development of our hybrid clinics. From a staff perspective, provider perspective, really most of us felt, well, half telehealth, half in person. Again, I think there was a lot of satisfaction with using telehealth. We became used to it. Again, there are some patients who felt, or some providers who felt that a different models would be preferable. So telehealth and quality of care delivery by patients and staff. So how would you rate quality of care during telehealth? From a patient standpoint, in the yellow, you can see there, they felt it was about the same. From a provider standpoint, also felt it was about the same. So I really think that both from our patients and provider standpoint felt that we could provide the same level of care with some caveats to that with using telehealth. So you can see the arrows there where I pointed out what I just mentioned. So what do our CF providers say about strengths? Okay, well, it provides flexibility for patients, childcare, work, school schedule, more time, convenience for patients, higher attendance for quarterly visits with telehealth as an option. There's no question patients call and say, hey, I don't want to come into my in-clinic visit, but I'm willing to do a telehealth visit. Potentially reduce cost related to travel time off of work. The use of home spirometry, I think, has really gone a long way to making virtual visits very productive. Seeing the patient in the home environment, as you just heard, I think that's something that's really, I think, adds to the visit. I can't tell you how many different environments I've seen patients in, it's sitting in their living room, sitting in their backyard. The one environment I don't like is when they're driving, and I do make them pull over if they call me driving, and at least be parked on the side of the road. We see less no-shows. We do have a subset of patients who even cancel their virtual visits. That one's a bit frustrating. and no infection control issues. And medication reconciliation is something that is easier. I think was mentioned in the last talk too. When you're on the video call and they say, well, I'm not sure what I'm taking, I say, well, turn around, get your medications, pull them out, let's see them. And they show me their medications, we get their dosing, we get it correct, which often in clinic we can't do. What do our CF providers say? Well, patients may be more distracted during the visit. They might have a child with them, they might have animals or pets, they have, their dishwasher going, who knows, there's something going on in the home which might distract them. We may not have sputum cultures. Visits often tend to be shorter. It's really interesting with virtual visits. For some reason, they just tend to be shorter. And it can be less personal because it's video and not in person. The issue of digital divide, which I talked about. And then challenges integrating telehealth and in-person visits and how frequently do we do one versus the other. And of course, unable to complete a physical exam assessment. What do our patients say the strengths are? They save on gas money. Childcare isn't an issue. Faster visits, and they like that. They're able to make their quarterly visits, so less no-shows. Home spirometry, it's less stressful, and don't need to factor in transportation time. And our patients, we're on the central coast of California, so our patients sometimes are driving 90 to 100 miles to see us. So virtual visits really, from a convenience standpoint, is huge. So what about weaknesses? Well, again, less personal. There might be connection errors. I think we've all dealt with this with drop calls, drop video doesn't work, don't have sound, don't have video. Some problem with the system. But it's easier to be seen by everyone in person, better assessment in person, hard to find private location for visits in-house, more distractions. Less hands-on with the home spirometer, may not be as accurate in some instances as spirometry in clinic. Arranging local testing can be difficult, so if they are far away and we're sending them sputum cups or labs, they might find that more difficult than actually coming into the clinic where they can get their labs more easily. Some don't like taking their own vital signs. And some just prefer the face-to-face contact. Again, it's more personal. And then some testing that can't be done with telehealth, such as walk tests. So, should virtual care continue to be an option? And I think there's a lot of issues that surround this virtual care. Can we continue to have, adequate multidisciplinary care? Can we continue to partner and work on continuous improvement, provide holistic care? And of course, the financial viability. And I think the payment parity, as I mentioned, goes a long way in that regard, and trying to maximize billing that goes along with virtual visits. So let's talk a little bit more about the financial impact, okay? Because I think this is really important, and it's really important for someone like myself who's running a CF program. So professional fees, so as I mentioned, parity of E&M codes for both coverage and reimbursement. You might see an increase in patient volume, so you might be able to capture more income or billings because of the higher volume. Home spirometry is reimbursable. But you lose 6-minute walk tests, you may lose full sets of pulmonary function tests, other testing that you would normally do in an in-person visit. From a facility standpoint, and I work at a hospital where we have, I'm actually contracted with our hospital, so I bill professional fees, our hospital bills facility fees, so these are separate. So looking at these separately is important for a center like ours. Where there is also parity of E&M codes on the facility side, but as I said, reduction in office testing, sputum cultures, imaging, which can be a big source of income for CF programs. From a patient standpoint, less travel time, less time off of work, less childcare needs, and less testing for them. And if they're on high deductible plans, that may mean a cost savings for them as well. So I thought I'd go through kind of the different types of visits and what's required. I think some of this unfortunately got cut off a little bit at the bottom as far as these codes. But the ones with the check marks here that you see at the top, virtual visits, online, digital E&M, and telephone, these are ones that we do. I really don't do virtual check-ins as of right now. But just going through the virtual visit, it's a two-way interactive audio-visual. It can be with new or established patients. Consent is needed. That's important. It can be verbal. It can be written, but it does need to happen. Can use everyday technology. Doesn't matter where you are, where the patient is. That's irrelevant at this point. For online digital E&M, so this is a HIPAA compliant patient portal, secure messaging. It's for established patients only. It really does need to be patient initiated, so they need to send the message to you. Consent should be obtained and can use everyday technology. It's typically asynchronous. It's kind of like emailing back and forth. And codes are cumulative over 7 days. And it has to be unrelated to an E&M visit within 7 days before or after. So if you are communicating with a patient and that leads to an office visit, that's not billable, okay? But if you have communication back and forth and let's say the plan is to order some testing or a sputum culture or you would prescribe a new medication that does not lead to an office visit, then these codes are billable, and I absolutely suggest to your centers to take advantage of that. And then telephone E&M calls, E&M visits, again, that's a simple phone call, really under the same guidelines as virtual visits, as consent. It could be provided by family members. Again, should be unrelated to E&M visits 7 days before or the next 24 hours. And there's codes for that, which actually do pay fairly on par with virtual visits. So what's documentation that's needed? This is what we use in our center. So this visit was provided through telehealth, verbal, written, provided, informed consent is to be conducted via telehealth. What's the location of the patient, location of the clinician, and who are the persons participating in the telehealth service and their role in the encounter. And then with the subsequent E&M codes and also with the place of service codes, which is really important for whoever does your billing. So I'll move on a little bit to remote spirometry. We've heard a lot about this at prior NACFCs, but I just thought I would review this because I do think it's really important. This is actually, this slide was actually provided to me by Zephyr, who provides the main dashboard that I think a lot of centers use for collection of the home spirometries. What we've done at our center is we actually don't use a dashboard because of the cost. We just have patients use the Mir SpiroBank app, and they email it to us, and then we just upload it to our EMR, so it gets around that cost, and then we can bill both a technical and a professional fee, depending on, again, from the hospital standpoint to bill a technical fee, from physician standpoint the professional fee. There is a code too for education and setup of the devices. So you can see here that this can be a significant source of income for your CF center if used appropriately. This is home spirometry codes for non-facility fees. And so if I were in my private office, for instance, this is what I would do. And we usually bill the 94014. So that's for transmission, data capture, and interpretation. Again, we don't use any portal or dashboard for this. So really there's no monthly fee, but I know a lot of centers who do take advantage of that for convenience purposes. So this is a little bit about the Cottage Health's virtual care timeline. So back in 2019, that's when we kind of started our virtual care program pre-pandemic because we thought that for convenience, because our patients were coming from long distances to our clinic, that it would be something that really would be helpful to our patients. And then all of a sudden COVID hit. We went entirely virtual. We went through multiple virtual visit platforms. We initiated home spirometry. We started mailing sputum cups in 2020. We then transitioned to more hybrid clinics, where I would say probably somewhere between 30 to 50% of our patients are hybrid or are virtual at this point. The rest are in person. We use a whiteboard to improve clinic efficiency. We have Corey Stritzel, who's in the back here, who's our sort of quarterback at our clinic. She's really helpful in improving our clinic efficiency. We use Epic as our virtual platform, and then we do bill and code for virtual visits. Hybrid clinics in the last year and a half, really have become routine. Billing, we do bill both professional and facility E&M codes. We bill for virtual, telephone, electronic visits. We also do chronic care management. For a lot of the patients who I don't bill e-visits, and there's a lot of communication between our office, a lot of out-of-office work, so to speak, that's being done. We do use chronic care management. I'm not going to talk too much about that, but it's something that I would consider your center to take advantage of because these are additional sources of income. We use the Epic platform, and as a backup, we use FaceTime and telephone. So this is kind of where we're at now. We have 5 to 9 patients in a half day, typically 8 to 12 in a full day clinic. It's typically a mix of in-person and virtual, and I will just say one size does not fit all. So you might ask us, how do you decide whether someone can be virtual or someone should be in person? It really depends on the patient. If a patient has relatively normal lung function, they're on Trikafta, for instance, and doing really well, they are living a significant distance from the clinic, then they're probably going to do more virtual visits. For others that have more advanced CF lung disease, who perhaps more symptomatic, lower lung function, we're likely to see those more in person. All patients, however, need to be seen in person at least once a year. Nearly all of our patients have home spirometers, but we do have the patients who say the dog ate their spirometer or, give some other reason that, they don't have their home spirometer. Vitals are typically taken at home prior to the virtual visit and recorded on our electronic health record. We discuss all patients at preclinic meeting, and we also usually identify patients who, at that point, if they are virtual, when was their last in-clinic visit so that we can make sure that they are being seen in person. So our efficiency is really important. We use a whiteboard. As I mentioned, we have our quarterback as our nurse coordinator. We mail sputum cups to patients distance from clinic. We also send them lab slips so they can get their labs locally, specifically for their annual studies. So there are many benefits, even outside of the COVID-19 pandemic, for virtual care. I think I've outlined some of that. We have all integrated virtual visit rapidly at warp speed into our CF centers. So I think we're all probably pretty good at virtual visits at this point. We worked on operational efficiencies, having a highly functional audio-video platform. It's so important. It was so frustrating at the beginning when we didn't have that. We have evolved into these hybrid clinics, as I've mentioned. I still think there's a lot to in the future to determine, what are the clinical benefits, if any, regarding lung function, BMI, reduction in exacerbations, and of course, financially, what are ongoing financial limitations and how likely is it to be sustainable. But I do encourage everybody in the room to take advantage of the new billing codes for home spirometry and for other types of visits, as I mentioned, to increase revenue for your clinic. I'd like to acknowledge the CF Foundation, the Dartmouth Microsystem Academy, and through our virtual improvement program that we did a few years ago. Randy Messier, Shanann Pai, and Bob Zani were our quality coaches, and they were really helpful in kind of getting our virtual care program off the ground. And of course, to my CF team, to Corey and our entire CF team, leave it at that.
Thank you, Dr. Belkin. We had a couple questions come in. The first question was, have you heard about some insurances not covering telehealth after December, was the first part of the question. And number 2, how long are your visits?
Yeah, I haven't heard of any, I haven't gotten any feedback about certain insurances that are not covering telehealth. That has not been an issue for us. I haven't seen any denials. And how long are our virtual visits? Yeah, I think it depends. It depends on how many team members they're seeing. Some, if it's a sick visit perhaps, and they're just seeing myself and maybe Corey and our clinical pharmacist, it may be a very quick visit. If they're seeing the entire team, then yeah, it varies. So it's hard for me to give a definitive answer. But again, it really depends on how many team members they're seeing.
Okay. Our next question was, is the patient financially responsible for purchasing the scale, thermometer, blood pressure cuff, et cetera, for the telemedicine visits?
Yes, that has been the case. We have found ones, I think Corey found ones that were relatively cheap in price to try to mitigate that. But yes, there wasn't any, remuneration back to patients for those things.
Okay. What electronic platform do you use for texting and FaceTime? That was a question I had when you mentioned FaceTime. How are you doing that, and how is that HIPAA compliant? And do you use your own cell phone for that, or?
Yeah, no, we actually use Corey has a cell phone that I think she has it with her now. That is our clinic cell phone, and it's a work phone. It's provided by our hospital, and that's the one that we use for FaceTime. Yeah.
We've got a question here.
Hello. Katie from the CF team in Philly at Jefferson. To speak to the telehealth coverage, in Pennsylvania at least, December 1st, Aetna will no longer cover telehealth. So that is a thing that's happening. I know every state makes different decisions, but that is happening in at least one state. Sure,
that's good to know. I mean, it may be happening in California too. It's nothing that I've heard of as of yet. So yeah, it will be interesting to see what as we move out of the pandemic, what insurance companies are they going to push back on telehealth visits.
Yes, they should be dictating patient care.
Yeah.
Anyway, my questions are, the once-a-year visit, you have it pretty well organized to get their annual PFTs at that visit, or what do you do about annual PFTs basically? Yeah, so we do PFTs. Generally, the PFTs, because I have a separate private practice, so our PFTs are generally done in my office. So the patients go to my office to get their PFTs and then come over to the CF clinic. So yeah, we usually coordinate that with their annual visit, where they'll do their PFTs, they'll do their X-ray, or if there's other annual studies that need to be done, if they need a bone density scan or they need abdominal ultrasound, we'll try to coordinate all the testing with that visit. Excellent. Okay. And sputum cultures, it sounds like you're doing some of them out in the community at like the big labs rather than your local one. So what are you finding with the results of that, since especially where we are, we try to send it directly in Jefferson to get the right plating and the results.
That's a great point. So we prefer to have it done with labs. There's a lab that we use, it's called Pacific Diagnostic Labs, and there's a pretty far outreach from Cottage, about 90 miles in each direction. So if patients are able to drop it off at any of those locations, they're done, with plating that, for CF cultures. But yeah, if they go to a Quest or they go to a LabCorp or they go to a lab that we don't have a strong relationship with to do CF cultures, we get what we get. Yeah.
I think we have time for one more question.
Thank you. My name's Jacqueline Davis. I'm from Boston Children's. Thank you so much for your talk. I have two questions, if that's okay. The first one is, you touched a little bit on the patient characteristics that you consider when deciding between virtual or in-person visits. Are there certain visit types that you reserve virtual visits for? Are they for routine quarterly visits only? Do you do sick visits, hospital follow-ups, home IVs? Are there certain age ranges too where you would?
Yeah, we really individualize it. It's hard to say, so I, usually we'll have a discussion about, whether virtual visits are appropriate for that patient. As I mentioned, I think for the patients who, certainly for routine visits, we definitely use virtual visits more for that. But, if the patient is, 90 miles from our clinic and it's going to be hard to get there, I'll do a virtual visit and then kind of assess from there whether, okay, do I need to have them come into the ER or to see a local physician there? So I use it kind of in a way to triage them to decide whether they really need to be seen in person. And we can get, as I mentioned, with if they have all of the ability to do vitals at home and they have home spirometer, really the only thing I can't do is listen to their lungs. So I can get a pretty good sense for how they're doing virtually and then decide from there.
There are digital stethoscopes that
Yes.
seen but haven't studied
Yeah.
yet. And then are you tracking any kind of outcome measures or healthcare utilization measures related to using virtual care?
Yeah, I think it's something that we're planning to do. We haven't done that as of yet, but I think it's something that, we're looking into as probably one of our next quality improvement projects.
Thank you. Okay, we'll welcome our next speaker. Is Sarah Webster-Mellon. She joined the Cystic Fibrosis Foundation in 2018 and currently serves as the Senior Manager for State Policy. In this role, she advocates for policies that support access to care and expand coverage for people living with CF. Before joining the CF Foundation, Sarah worked as a contractor for the U.S. Department of Health and Human Services and for a nonprofit focused on outreach and education around the Affordable Care Act. She holds a Master's of Public Administration in Health Policy and Management from New York University.
Thank you so much. Good morning, everybody. Happy to be here on this panel, and thank you to our moderators as well. So this morning I'm going to talk a bit about the snapshot for the policy landscape about some of the issues that have been brought up this morning. I do not have any relationships to disclose, but I will say that I have not yet had my morning coffee. So I was telling the panelists that before we started. So picking up on some of the themes that we've discussed so far, Dr. Belkin talked about this. There was an explosion of telehealth during the COVID pandemic. And so we saw this massive uptick in providers using telehealth, including APPs. And just to provide a snapshot of what this looked like, you know, by discipline, in February 2020, just 1 out of 10 physician assistants were using telehealth regularly in their clinical practice. Fast forward just a few months, and we are seeing over half of PAs were using telehealth, and 3/4 of those did not use it at all before the pandemic. So I think that echoes the steep incline that we've been talking about in the uptick of telehealth during the pandemic. Luckily, state and federal governments both moved very quickly to ease regulations and restrictions around telehealth. But now, a couple years later, we are starting to see some of those, at least regulatory and policy flexibilities end or evolve, and there's more variation. So one theme that I've heard picked up is that there's variation between states and within payers, and I think that's a challenge now, is that we're seeing some states try to make some of these flexibilities permanent, but there is a lot of variation between and even within states about what that looks like. So I don't need to tell you that there are many considerations that go into providing telehealth. So first, state licensure. What provider types are licensed in the state, what different states are they licensed in, and how does that impact your center's ability to provide care, complying with HIPAA regulations. Different payers are going to have different reimbursement rates, policies, and different considerations that they allow within their plans. Reimbursement, as we've heard brought up today, is there parity? Are there facility fees that you can charge? A number of financial considerations as well. Within payer type, we have some legal requirements within Medicare and Medicaid. Those can look different, those can overlap, and so it's really a patchwork system of requirements that providers have to consider when they're providing telehealth to their patients. And then, as Dr. Belkin talked about, a lot of financial and administrative costs, and I think we're still interested to learn what these look like as the care landscape evolves and as we see the policy landscape move beyond COVID and see what shakes out in terms of what becomes permanent and what was just an emergency flexibility. So lots of considerations that providers, including APPs, are having to take into account when offering telehealth. So just want to acknowledge that. So what does this look like for APPs? Cindy, George, and Lauren Katz is here this morning. Thank you for joining, Lauren, from the foundation. They fielded a survey of APPs in cystic fibrosis care programs across the country. And so really interesting data that they have. Many questions beyond telehealth, but just focusing this morning in on what that told us about the practice of telehealth among physician assistants and APRNs. So currently, we talked about the proliferation during COVID of the providers who were providing telehealth, but now I believe this survey was closed earlier this year, so relatively recent data. We see that the vast majority of APPs are either providing no telehealth as part of their clinical practice or only up to a quarter of their caseload. We have some folks, the largest category here is over 70% of APPs are providing up to a quarter of their outpatient care as via telehealth. Much smaller percentages when you look beyond that amount of the caseload that's able to be conducted via telemedicine. So this, as you can see, is responses from over 60 APPs from across the country. When we dug into this a little bit, asking, are there restrictions or limitations on the practice of telehealth that may be impacting that? Over 40% that said that yes, there were restrictions or barriers that were impacting their ability to provide care. And the primary theme, this was an open-ended question, so it was not multiple choice. You're welcome to provide whatever description of the barriers felt right to you. And the primary theme and the primary limitation was state licensure requirements. Switching gears a bit just to see the proportion of centers that are serving out-of-state patients. This data is a little bit less recent. This was fielded by Kathy Sabadosa from the CF Foundation via the State of Care Survey in 2021. It's published in the Journal of CF, and the citation is cut off on the screen, but not on mine. So you can see that in the slides. Asking, does your program have patients located in a state other than the where your center is located? And 3/4 say yes, we have patients who live in another state. So that is a wide swath of CF centers that are serving patients out of state, which makes sense when we think about the type of specialty care that's needed for CF and how these centers are geographically located. And then we asked, since the onset of COVID-19, have your program's clinical care team members obtain out-of-state licenses to deliver telehealth services to patients? So it's not asking about discipline specific, but in general, has there been somebody at your care center who has gotten additional state licenses to provide care to those patients? As you can see, over half said, no, we haven't gotten additional licenses, but yes, about a quarter have gotten additional state licenses for some of those states where patients live, and a smaller chunk, about 14%, where all patients, for states where all patients live. So a mixed bag here. And again, I think picking up on the theme of out-of-state licensure requirements being a challenge. So in monitoring the policy landscape, we're looking for what solutions are out there. If we hear that out-of-state licensure is a barrier to providers getting licensures or getting privileges to practice in another state, and we know that the vast majority of CF care centers do serve patients in other states, what kind of policies are out there? So I just wanted to share a couple examples of those with you this morning. So the first is the APRN Compact, which was adopted by the National Council of State Boards of Nursing. This is a relatively new effort that would create one multi-state license. So it would extend to both in-person and virtual care, but obviously be used predominantly for telehealth if it's used for patients in other states. So there are a number of requirements. You have to have a certain number of hours, standing, lots of details there, but you have the, once you have the multi-state license in your home state, you have the privilege to practice in other participating compact states. So the goal with this is really to reduce the time and cost of obtaining additional licenses. So looking at where we are here, I think a challenge for this compact has been the adoption. So in order for this compact to go live, 7 states have to enact the legislation. So we are not yet at 7 states. As you can see, the blue states, the dark blue states, Utah, North Dakota, and I believe that's Delaware, that tiny state on the East Coast. Those are states that have enacted the compact. And so there's not yet currently enough states for this to be active. Similarly, there's a physician's assistant's licensure compact, and it's similar in that it aims to ease the administrative burdens of being able to provide care in multiple states, but a little bit different in that you would get one license for in your home state. But then you would have to, if you wanted to provide care in other states, you would have to go to the commission that's administering the compact and say, you know, I live in Pennsylvania, but I want to administer telehealth care in New Jersey and Delaware. Then you would do some background checks and you would get what's called a compact privilege. So it wouldn't be a full separate license, but it would just reduce some of those barriers to practicing in another state. So again, I think some current themes is getting kind of the momentum to have enough states to have this compact go live. So in this map, we just have 2 states that have adopted the PA licensure compact, some other states considering, but we don't yet have 7 states that have enacted and passed legislation to join the compact, so that's currently a challenge. We have seen momentum in other compacts, though, that I think these both are models of. So you may have heard of the Interstate Medical Licensure Compact. That's for physicians. Over half of states have joined that compact, as well as the Nurse Compact. The majority of states have joined those compacts. So I think there are models where once there's enough buy-in from many states, it is more usable. But currently the PA and APRN compacts are not at that state, but just wanted to make you aware of these efforts as they're ongoing. To shift away from out-of-state licensure and to touch on coverage and reimbursement policy, what we're seeing is, as I mentioned before, there's efforts, states are kind of saying, okay, well, we have the COVID era policies that are coming to an end. What should we keep permanent? What's temporary? What just served us in an emergency situation? And what should we make permanent? So we see a couple different flavors being considered at the state level in terms of reimbursement. So one flavor of this is coverage parity, and this is requiring the same services to be covered via telehealth as they would be covered if they were delivered in person, but that doesn't guarantee the same dollar amount in terms of reimbursement. So the next layer beyond that is payment parity laws, which do require the same payment rate or amount to be reimbursed via telehealth as it would be if it had been delivered in person. So different flavors of the same concept of trying to get telehealth services covered and reimbursed moving forward. So what does this look like across states? We know that 21 states have implemented policies requiring payment parity. 8 states have payment parity in place with caveats. So you can see in this key, there's a lot of, unique situations where they have payment parity, but they're expiring. For example, Maryland's is just through June 30th, 2025. So lots of variations on what this looks like. And 21 states have no payment parity at all. I think another challenge when we talk about states is acknowledging the patchwork system that we have. So even if there are state laws that are on the books mandating either coverage or full payment parity, that's only going to apply to a certain type of payer, only state-regulated payers. Then there's Medicare, then there's Medicaid. And so I think that's part of the challenge is that not one state law is going to affect all plans. Same with one federal law. It's really patchwork at this point, which does make it confusing for you at the centers when you have patients with different coverage types. But from this map, we do see that there are efforts underfoot to make at least some form of parity permanent, which is encouraging. Specifically focused on Medicaid, the good news is that all state Medicaid programs in DC reimburse for live video services. Talking about all telehealth modalities, at least 11 states require Medicaid coverage for the 3, main modalities: real-time, store and forward, and remote patient monitoring. And unfortunately, within this, provider type services and locations eligible for reimbursement vary within state programs and between Medicaid programs. So where are we headed? What themes are we seeing? telehealth has become a more accepted form of healthcare delivery, but the rules, regulations, and reimbursement policies vary widely by state, provider type, and payer, which can be confusing for providers, can be confusing by patients. And then state licensing requirements continue to pose challenges for providers, including APPs. And knowing that a majority of care centers serve patients living in other states, this is an issue that we believe affects multiple care centers across the country. We do see that states are adopting permanent flexibilities, but the pace of this has slowed. I think immediately in 2021, 2022, there was a robust conversation of saying, look how great telehealth has been, look how much this has expanded access, look how well this is addressing health equity, social determinants of health, rural access problems. And that discussion has morphed and slowed, I think. I think policymakers and payers are looking for data on outcomes, on value related to in-person and virtual care, and seeing what the outcomes of those are. So I think the discussion is continuing, but the pace is a little different by nature of, opening the floodgates during COVID. I think we're seeing the pace become very different. As I said, decision makers are increasingly seeking data to make these decisions about making policies that mandate certain services and policies to be covered, or for payers to reimburse at a similar rate. But we are seeing policy solutions. Like I said, there are a number of compacts out there that are seeking to ease at least the out-of-state licensure piece of this that are gaining traction. And so we are continuing to monitor those efforts at the state level. So I'm happy to take any questions that you may have. Hi. Thank you.
You mentioned at the end this important need for data on
Yeah.
outcomes. Is there anything you know within the CFF in terms of trying to coordinate that data collection and synthesis?
Sure. Do you mean in terms of like clinical outcomes for telehealth? So
Or even use. I think we still don't even know who's using telehealth and how.
yeah, I think that's a great point. And I think we're at an interesting point of time with the advent of Trikafta and highly effective modulators. I think that's an open question of what we're looking at is how is the care model going to change as these patients' lives change, which is great, but is the 4 care center visit model a year, is that going to be the model moving forward? And so I think the convergence of that, how is care rapidly evolving? How are centers using telehealth? How do they want to use telehealth? And how do patients want to use telehealth? I think the answer is that there is a role, but I don't think we have, as you said, the data to see what all of those factors look like. There are ongoing studies at the foundation looking at the evolving care model and what can fall off and what does care look like moving forward. And I would just encourage you to stay in touch about your experiences, about how you're using telehealth or not using telehealth. Do you want to be using telehealth? I think even that anecdotal data is really useful to know, to inform policy solutions. So I don't know if that answers your question, but yeah, thank you.
Sounds like a survey could be helpful.
Yes. And the State of Care survey that I mentioned, which is published in the Journal of CF, that talked a lot about and asked a lot of questions about use of telehealth, success of that telehealth. And then we also had a survey on the patient side that asked about their experience of care. And so I think both perspectives are important, and I think echoes the underpinning theme that the modality should be determined ideally by the provider and the patient, what's most appropriate. And as we've heard about so far, that could depend based on service. It may not be a blanket, all telehealth or no telehealth, but it could be telehealth for these services and not others. So I think that's very much evolving.
I had a question, kind of she asked about data collection. My next question was about advocacy. So do you know if the CF Foundation is advocating for telehealth reimbursement and those interstate compacts, for example,
Yeah.
on either the state or national level? And if so, how can APPs get involved?
Yes, I love that question. So just to zoom out and to provide an overview of our advocacy on telehealth overall, we, like much of the world, kind of jumped on the telehealth bandwagon in 2020, and we moved quickly to advocate to states, Medicaid, Medicare, all audiences, to push them to remove all the restrictions that they could. So we supported many of the policies that Dr. Belkin touched on, or removing originating and distant site restrictions, covering and providing reimbursement for audio-only services, expanding the range of provider types that are eligible to provide telehealth services. And, we talked about how multidisciplinary CF care is, and that nurses, nurse practitioners, PAs are part of that model. And then also the importance of interstate medical licensure. So we have been advocating for that for a couple years now. As we move forward, we are certainly looking for policies that we can support that build on some of these concepts and make them permanent. So for example, we look at states like Wisconsin and Michigan, who they have really great Medicaid programs that are saying, we want to, institutionalize some of these policies. We want to make audio-only services a part of our care moving forward. And so I would say, yes, we are definitely monitoring and supporting those policies as we see them. I would say the other part of that is what I said before about constantly intaking information about what both patient and provider preferences are, and then making sure that our advocacy reflects those priorities, and that we are advocating for priorities that meet both of those groups' needs. So would love to have you involved in advocacy. I will be here after the panel and would love to give you my card. I would say stay in touch with the Policy and Advocacy Department at the CF Foundation. Clinical Affairs does great work and fields a number of surveys and research and calls that bring together disciplines. So I would say stay in touch with the foundation. You can sign up for action alerts on our website, which will notify you. It's not specific to these issues. It's on the range of issues that we work on around access to care. But those are some ways that you can stay involved if you're interested in this.
Awesome. Are there any other questions?
I think if I stand here, you can hear me?
Yes.
Okay.
We can hear you.
So I'm Mary Gant. I am from that little state on the East Coast, Delaware. Delaware is usually very progressive with getting involved in compact acts, so I'm pretty proud of that. So one of the other issues with licensure is not just only licensure into other states. Delaware is very unique in its geographic, where you can go kind of 15 minutes in any direction and be in one of the other 4 states in the area.
Yeah.
So we get patients who definitely come to us from other states. And so, during pandemic and the emergency use, and we were all licensed in all of those 4 states.
Right.
And so it didn't matter. But now, I know I myself have been waiting for over a year for my New Jersey license. Took me 7 months to get a Maryland license, and I'm still waiting for Pennsylvania.
Right.
So just insanity of what that's like. But the other piece of it is, and I know we don't prescribe a lot of controlled substances in cystic fibrosis, but then that's another issue, is that you can be licensed. Once you get licensed in another state, you cannot prescribe a controlled substance in another state unless you get a DEA license in another state. You can renew a medication, but you can't prescribe a new medication for a patient. So if for some reason you were wanting to, even if you're work outside of CF care as well, you can't prescribe that unless you get a DEA license, which is upwards of $1,000 in each state, right? So there's just so much, and it's so disheartening to hear from my colleague there at Jefferson about Aetna. I had not heard that yet. Another colleague sitting here saying it's happening in Virginia as well. There needs to be significant advocacy for that, not just for CF, for all patients getting virtual care, because that's insanity to me as to why there would be a reason behind that.
Yeah, thank you for sharing that. Could everybody hear the comment?
Yes.
Okay, great. Good projection. No, and I think that underpins a lot. It adds another layer of complexity too. It's not just the licensing, as you said. It's how much buy-in do you have from your center to pay for some of those administrative costs? How long is it going to take you to get the license? So a very imperfect system, I would say. And I agree with you. We need to continue to advocate to make it better.
Thank you, Sarah.
Sure. And I would just flag, if I can flag one more thing, if you're interested in these issues, the Center for Connected Health Policy has a ton of resources on all of the issues that we discussed and more, and they break it down between federal and state government. So I would encourage you to look there and reach out to me directly if you have any questions. Thank you.
Our next speaker is Angela Oder. She is a board-certified adult nurse practitioner currently working in CF at UC Health in the pulmonary division. She received her doctorate from the University of Cincinnati and her master's from Northern Kentucky University. Her current research interests are in reproductive health in CF and decreasing the treatment burden for people with CF.
Thank you. Yes, so the only disclosure I have is I have a little bit of funding from the Cystic Fibrosis Foundation, but not in regards to this presentation. This presentation and project was also developed while I was in the LEAP program. So I am at the University of Cincinnati, and we currently have 200 adult patients. 22 of those patients live about an hour away. We have 4 providers, which consist of 3 physicians that rotate in and out of clinic, and 1 APP, which is myself. We have 7 half-day clinics a week, which vary depending on physician service and their responsibilities for consults. Sorry. There we go. So we all know that there's a high treatment burden for patients with CF. In addition to their daily CF care, they are required to be seen 4 times a year for routine visits by the CF provider. And additional visits may be required if the person is sick. We know they need to travel to the CF clinic. They may need to take time off work, which may add to their financial burden. May need to take time away from their families. They may need to arrange for childcare, and they may even need to stay in a hotel if the clinic is far from their house, which we don't currently have that at Cincinnati. There's several CF centers around. So with the assistance of our patient family partners, we created a project. The aim of our project is to decrease the burden of care by converting in-person routine visits to telehealth visits for stable patients. The first thing that we needed to do was define stability. So for us, stability meant no exacerbations in the last 6 months requiring IV antibiotics or hospitalizations. They had to be compliant with their medication regimen. They have to have completed up-to-date annual lab work in microbiology. There's no mental health or nutrition concerns. The previous visit was completed in person. They must have a home spirometer and be able to use their home spirometer. I actually had a sick visit via telehealth last week who was very concerned because his home spirometer showed that he dropped his lung function by half. I reviewed his home spirometer with them, and the effort was questionable at best. So I did bring him in and converted his telehealth to an in-person visit and was able to do a PFT in clinic, and his lung function was stable and normal. So the RT was able to provide him some education on how to use his home spirometer in the future. And I know that this has already been covered, but during the COVID era, our multidisciplinary team would all sit in the same room and call the patient first. They would pass the phone around to each other, so everyone was able to participate in the patient's care. The home spirometer was recorded for the RT, and she could also provide education as needed over the telephone to patients. The team would let the patient know that the provider would complete their visit via telehealth next. And this is just how we ran the clinic flow during the COVID pandemic. And initially, the providers would do the visit first, but what we noticed is that some patients would not answer the phone for other team members. It's unclear if they just did not see the value of the multidisciplinary team, or they were just busy and just could not participate. So during this post-COVID era, we would have a weekly huddle and review the patient's schedule for the week and determine which team members needed to see which patients. And if the provider was seeing the patient via telehealth or a mental health or nutrition concern arose, we would alert the other team members and they could follow up via phone or at the next visit, depending on the issue. So our patient family partner created a letter detailing the project that we decided to create, and we mailed this letter electronically and hard copy to all of our patients. And then we created a list of patients that were scheduled to be seen that week. We would determine if they met the stability criteria and review this Tuesday at 2 p.m. with our entire team. Our multidisciplinary team members would weigh in if they had any mental health or nutrition concerns, and if they did, then we would keep that person scheduled as an in-person visit. If all the team members agreed the patient met the criteria, we would provide the list of the patients to the schedulers. The schedulers would then call the patient or send a MyChart message, and if the patient accepted the visit to be switched to telehealth, the scheduler would update the schedule. So here's our letter that was created by our patient family partner. It basically states that a majority of people are starting to feel better on the highly effective modulators, and we are trialing a new process to reduce the burden of care for a small select group of patients who meet a certain criteria to convert their in-person visit to telehealth. If they met this criteria, a scheduler would call them and offer to change their visit, and that the overall goal of this project is to come up with a new process to reduce the burden of care. So here's our data of telehealth visits over the months. Our numbers waxed and waned depending on provider schedule, how many patients we had scheduled for that week. And as you can see that there was the spike in November of where everybody was converted back to telehealth because there was a spike in COVID cases. So initially, when we started this project, we wanted to know what patients thought about their telehealth visits. So we sent a survey to 5 patients early on during the project, and it asked them to rate how they viewed their quality of care at their last telehealth visit compared to in-person visits at the clinic. And for 1 was poor and 5 was excellent. They were also able to write in if they had any additional comments. So 4 patients answered the survey, and 3 out of 4 patients provided a 5 out of 5 scores, which meant that they thought their telehealth visit provided the same level of care as their in-person visit. And 1 patient gave it a score of 4 out of 5, and she wrote in that she felt that it was just a less quality of care because she did not get a physical exam. So we noticed some barriers to the project, which included this clinic staff getting busy. We were not able to pull reports. Our weekly meetings may be canceled. Not all team members may be present to weigh in during our weekly meetings, whether due to vacation schedules or service responsibilities. And other barriers include that our schedulers get busy, they're not able to call the patient or send a MyChart message. Some patients may not answer their phone or see their MyChart message. And some patients may feel that they do not receive the same value of care compared to in-person visits, so they may decline to participate. There are also financial barriers, which Dr. Belkin described, which I will reach out to get his PowerPoint later. So this includes reimbursement that decreased from the pandemic era. So the federal government supported similar pay for virtual visits compared to telehealth, but they did not cover the hospital or facility fee. And now most insurances pay a reduced rate for telehealth visits, and the hospital or facility fees are not covered. There's also communication barriers, so a stable internet is needed for the provider and the patient. The patient has to have a home spirometer, a smartphone or computer to participate. And I have one patient who's in her 70s who does not have internet or a smartphone, so we have to do her visit via telephone. There are also licensure barriers, which we've kind of heard about. So I am an RN and licensed as a nurse practitioner in Kentucky and Ohio, but I am an RN in Indiana with a telehealth certificate, but I was not able to get my APRN in Indiana because I do not have a collaborating physician in Indiana. So this means that I'm able to see Indiana patients, I'm able to bill for Indiana patients, but I'm not able to prescribe to Indiana patients. So my collaborating physician will have to prescribe to them. And I am the only provider in our center that can see telehealth Indiana patients, which I find that very interesting. So my project has started to evolve, and we are now when we see patients for their routine in-person visit who meets all the criteria for stability, we can offer their next visit to be done as telehealth. We also have a dedicated telehealth clinic day, and we've noticed that for us, the clinic flow can be challenging when there's a telehealth patient scheduled in the middle of clinic of the day. For me, that telehealth patient will usually end up being pushed to later in the day if I start to run behind. Or their appointment may even have to be changed or canceled. If an in-person visit is canceled at the last minute due to transportation issues, we can try to schedule them on that dedicated telehealth day. And now all of our rooms are equipped with telehealth equipment, and even the dictation room, because that was one of the barriers initially, especially as the space in the clinic is pretty tight. And as previously mentioned, we've noticed that there are several benefits from telehealth. It opens space in the pulmonary clinic. It decreases the risk of cross-contamination. A majority of patients are satisfied with telehealth. It allows for close follow-ups and extends accessibility to patients. And we are able to bill for interpretation of home spirometers, which helps cover our dashboard. Thank you.
Thank you so much for your talk. Did you collect data, or do you have a sense on, of all of those eligible patients for telehealth, how many declined?
I do not. I do have that data, but I don't have that right offhand. And I believe it's just a small subset of patients.
So most seemed interested.
Yes, and I remember there one particularly that declined because she said that she had a cold that day and wanted to become and seen to get a physical exam and PFT in the clinic.
Got it. And the other thing that had occurred to me was, do you have a sense, or are you collecting data on rates of no-show between in-person visits and the virtual visits when they're offered?
We will be looking at that, and I know that we can pull that from Epic. But yeah, that is a great idea.
Interesting thing.
Yes.
To keep track of and help advocate for.
Yes. Yes, especially as they cancel for like transportation issues and yeah.
Thank you.
Thank you.
Hi, Clay Callison from Knoxville, Tennessee. Thank you so much for the great presentation. I actually trained at UC, so it's interesting to see your all's work. My question is the behavioral health being a kind of an exception, how you rule out for telehealth if you have a behavioral health issue, depression, etc. Curious if you all have specific experience with that, because behavioral health is usually kind of why people do telehealth, and so kind of interested if you guys have a bad experience or there's specific concerns that you guys have about that. Thank you.
Absolutely. So when we created this project, our social worker weighed in, our multidisciplinary team weighed in, and one of the concerns from social work is that she wouldn't be able to meet with the patient to get that read and that personal connection. So if there's somebody that she knew who had ongoing mental health concerns, that we would just bring them in so she can have that one-on-one interaction with them.
Okay, so it's in more staff concerns.
Yes, yes.
We've had a question come in on the app. Did you notice any change in compliance with annual labs after starting this program? And was this an incentive for patients to get their annual labs?
We did, because I was able to complete the visit and we were able to talk about that. And then if I had like an in-person visit and we were thinking about doing the telehealth visit next time, if their labs were due at the next time, we usually would agree to bring them in person at the next visit and then do a telehealth visit the following one. So we can kind of rotate that, because we prefer that in-person, then telehealth, then in-person, then telehealth, just to allow us to collect the data.
I know you mentioned you have your virtual clinic days. I think that's really a neat idea, because I agree we experience the same problem where we have telehealth visits mixed in with our in-person visits, and we are always late for our virtual visits. And it's like constantly the nurse coordinator or staff member is having to call the patient and say, it's going to be another 20 minutes. It's, like constant updates. So how do you like doing the virtual care clinic days? And how many patients are you seeing on the virtual clinic days on average?
So this is newer within like this month, actually. And it's on a Friday morning. So we're usually averaging about 3 patients. And I noticed that if a patient cancels during the clinic day, like it's Tuesday through Thursday, sometimes if they have like scheduling issues, I'll even offer to flip them to the afternoon to complete their telehealth visit, as long as I have like availability. So I love the fact that it gives me so much flexibility with my schedule.
That's awesome. Are there any other questions? Thank you, Angela.
Thank you.